Welcome to the Totally Adequate podcast, produced by Quest Analytics. Here, we dive into the latest news, policies, and innovations in healthcare provider network management with industry leaders who are shaping the future of care. Our mission? To elevate community health across the nation through superior provider networks.
Welcome to the Totally Adequate podcast. I'm your host, April Beane, VP of Marketing here at Quest Analytics. Today, we're going to be diving into provider network intelligence and performance. I'm joined with two distinguished guests who know a lot on this topic. I'm going to allow them to introduce themselves here in just a minute, but it's Bob Tavernier, Solutions Executive here at Quest Analytics, and Dr. Luke Hansen, Chief Medical Officer at Arcadia. We're going to be discussing the critical aspects of building better networks, the insights and drivers that help payers get there, and the evolution of member consumerism and regulatory pressures. Welcome, Dr. Hansen. Welcome, Bob. I'm so glad to have you here today. Dr. Hansen, why don't you tell us a little bit about yourself?
Yeah, thanks, April. Happy to be here. Looking forward to our conversation. I'm Chief Medical Officer at Arcadia. I'm an internist. I'm a practicing hospitalist in Chicago. I have a couple, I have a couple aspects of my career I like to share because it gives context to some of my opinions. First off, I started my career as an academic hospitalist doing research on transitions of care and the readmission metric. I moved after several years of work in academics to be CMO for population health at a large multi-hospital system in the Chicago area. And there helped support an MSSP ACO and Part B risk commercial product among other populations. And then also spent several years with United Health Group, both on the UHC side and with Optum before joining Arcadia. A short bit about Arcadia. We are a data integration and analytics company. So we take primarily claims and clinical information out of EHRs. We marry those together for our customers so that they can derive analytic insights from those around utilization, quality, and really all the levers associated with value-based care to deliver best outcomes.
Dr. Hansen, love your background, just from a provider perspective to a payer perspective to a technology perspective. So wonderful to have you on the call and to be able to talk with you today. My name is Bob Tavernier, and as April had shared, I'm a solutions executive here at Quest Analytics. My background is predominantly in the payer space, served in a number of leadership roles, not only from internal operations to external operations, having the opportunity to help to build networks from a product perspective, helping to work closely with clinical operations and what does that mean in terms of the intersectionality between network and clinical, as well as supporting business development efforts at Healthcare Service Corporation, which is one of the largest Blue Cross Blue Shield plans within the nation. So happy to be here today. Thank you.
We're so glad both of you are here. I think to get things started fundamentally, I think there's some evolution around this. There's some nuance to that definition. It's getting beyond just patient experiences and moving into patient outcomes. And there's more and more and more insights and data that's available to payers today. So Bob, I'm going to start with you. From your perspective, what are the key characteristics that you think today are defining what a high quality provider network is, especially in terms of breadth and access?
Critically important, high quality networks, when you think about it, it's truly foundational. When you think about not only the member experience, but also thinking about health systems, thinking about providers, and truly thinking about what is that member outcome? How do you help to support members? If you're thinking about high quality in terms of proactive care, those familiar with HEDIS performance measures, so many of those HEDIS measures are screenings, right? They're focusing in on getting the member to stay ahead of where they could unfortunately end up being with a comorbidity, a disease state. So truly thinking about the ability to provide care in a high quality environment, helping to give them not only the right level of care, but at the right time, in the right place, and then ultimately helping to reduce clinical outcomes. You can definitely see when you think about high quality providers, they have better outcomes, lower readmissions, lower ED visits. Members are in a facility for a lower amount of time because ultimately they're getting the care that they need. The providers are following closely the clinical practice guidelines that are defined within their given specialty and ultimately helping to support the members. So it's absolutely foundational to have high quality providers, not only from a member perspective, but then even if you think about it from a healthcare perspective overall. High quality networks are critically important to really being able to help manage utilization, thinking ultimately about the ways to help to support members through their care, but also being able to reduce costs in the long run and being able to further be able to support a broader base of the member community. When you're really focusing on high quality networks, you need to understand what the member population that you're serving. You need to ensure that you are meeting regulatory requirements. That's foundational. That you've got not only the right level of primary care, the right volume, but also the right type of provider type specialties that are not only supporting the depth and breadth of the network, but also getting into access. The industry is continuing to change when you think about access. Gone are the days of time and distance. That's almost accepted as a given. Everybody knows you've got to have a provider and a doc that's readily available. But then when you truly think about access, is the provider available? Are they accepting new patients? What's their appointment wait time? Things that truly think, again, back to that member experience and what does access to care mean to that member? So a lot of these ingredients are all conglomerated together to truly make up a high quality network.
Like we said, there's a lot of data, a lot of insights, a lot of things to comprehend and digest when you're trying to create this high quality network. So Dr. Hansen, I'd like you to build on that a little bit. When we're starting to talk about beyond time and distance, and we're starting to talk about patient outcomes, we're talking about costs, we're talking about patient satisfaction. These are all things that we're starting to look at, especially when you start to think of how digital our world has become. So how would you add to that as far as, defining what a high quality network is when you're starting to look at, the digital world we live in today?
Yeah, for sure. So I would say it's helpful to map this examination of what a high quality network is to the triple aim or the quadruple aim now. Bob, you made great points about access and how that definition is evolving. I would just add that there are aspects of access that have to do with the interpersonal experience of receiving care for patients, and that's, traditionally that's been sort of an accident when you find a doctor that you really fit with. As patient engagement, patient experience has become a more and more prominent part of a high quality network. I think that experience aspect, which I think translates to better access, which is to say patients are using care when they need it appropriately and proactively as opposed to reactively once the symptoms get sort of past some point where they can't stand it anymore. We need to be creating networks where a participant, which is to say a member, a patient, is going to opt in, is going to lean into going and meeting the physician or the other members of the care team willingly and enthusiastically. Is there a digital approach to that? Well, I think there is. I mean, for one thing, there's virtual care options. I think that's kind of we all experienced that in the last 5-6 years. That is absolutely a multiplier on access. I think there's also, though, an opportunity to unlock some shopping behaviors or some better matching behaviors between patients and providers. For my career, I feel like the thing I always fall back on when people ask me for a referral for a provider is I say, well, this is who I would go to, and I would say go there. But if it doesn't fit, don't settle for that, because I think that finding that fit is really essential to having the trust that it's going to take to have a therapeutic relationship. So to the extent, and this is probably a little bit looking forward, to the extent we can digitize that and help match people right off the bat with the right source of care that will resonate with them, the better the outcomes will be. So that's, I'm kind of eliding pieces of the triple aim there, but I think that actually quality, cost, and access are very intertwined as we think about how to put a good network together.
That's interesting. The consumerism part of that you were talking about, we're going to get to in a little bit, because I want to dive a little bit more into that. But before we get there, I think there's a middle part we need to cover first. So, all right, we talked about what a high quality network is, and that's great. And there's a little nuance and definition between the two of you. There's anyone you ask, there's probably a little bit of a nuance and difference there, but nonetheless, we're trying to build to it, right? And the payers are trying to build to that. And there is a lot of challenges and obstacles and, success stories out there as well of how do you start to begin to design a high quality network if you're a payer. So Dr. Hansen, this time I'm going to start back with you. You're a provider yourself. And so really interested in your insights on how designing a high quality network can impact about the quality of care and outcomes, which you touched a little bit about, but why is designing a network this way? Why is it important? And how do we get there as a payer? That's a big ask, right? When foundationally we want to have to be compliant first, but we also need to take care of our members. And so how do we get there?
That's absolutely. So I'll start with kind of I think the thing that many of us realize, which is that coverage does not equal access, and access does not equal a good experience of care. And really the goal that everyone has in the system, certainly patients have, is that good outcomes of care, a better life, that they can live fully. So how do we build a network that can deliver not just adequacy, but really an excellent experience that will improve lives? And the way that I think that we should do that is fully leveraging the observable experience of those that have already received care, which is to say, there's publicly available third-party data that we can use to profile the quality of care and levels of access that individuals historically have received from providers, and we can create sort of virtual networks to understand what that experience would have been like had the network been comprised of slightly different providers. I think that the thing that gets me very excited about that is that as you tune that opportunity in network curation, we can start to figure out what network would deliver the highest value, sufficient that we could introduce additional risk to that network. I'm personally a big believer that delegating risk, financial risk for performance and for cost is kind of essential to the sustainability of our healthcare system. And I think that we haven't really addressed network curation with that goal in mind sufficiently. We've addressed adequacy because there's regulatory requirements, and I'm looking forward to the time in our industry where we are able to curate high performance networks and productize those so that those purchasers that are willing to go on that journey sooner rather than later are equipped with a tool, the product network, to deliver that to their members.
So, Bob, I'm going to let you build on that, but I'm curious, how do you start to measure the effectiveness of that? Like when you're doing the provider design, and Bob, I know you can touch on this a little bit. And I guess as you're starting to do that, it has to align with the organizational priorities, right? So the payers right? Foundationally, it's great you want to do that, but as you're doing that network design, it's got to align with the priorities that you have set forth for the payer for the year as well. So Bob, maybe touch a little bit on how do we measure this as we move forward, and how do we ensure that it's going to align with those strategic priorities that the organization is trying to achieve for the year?
Absolutely. Quest Analytics partnered with Becker's Healthcare in Q1 of 2025, earlier this year. The top 3 organizational priorities were improving clinical outcomes, improving the member satisfaction, as well as lowering administrative costs. When asked about network design and really the data that supports that, it was essential. Same executives, so this was 100 executives that were asked to take the survey. They represented directors up to C-suite, multiple lines of business, and wearing various hats from network development to compliance when they really thought about the network design, the top three categories for network design had a heavy correlation to the 2025 top organizational priorities. Again, improving member satisfaction, improving clinical quality. I'll add a third area beyond the administrative cost of really helping them to focus in on building new networks, expanding their lines of business, thinking about growth and profitability. Network design was absolutely critical. In terms of data, when they really think about the ability to utilize data, they not only want access to digital information, concise information. Dr. Hansen, you spoke about having access to high quality data. When they took the survey and really are focusing in on competitive data, there was 72% that saying we need access to high levels of competitive data, yet none of them had access to high quality data. So 72% are saying, absolutely, we need this. It's essential to networks. It's essential to our organizational priorities, but none of them had access to high quality data. When really looking at the lens of cost and efficiency, we've talked a little bit about that. 62% said that we need access to this level of data, but yet again, they had a poor experience when truly thinking about data. So when you're thinking about grabbing different data sources in the industry and trying to kind of piece it together, we all know that data coming from different places has different methodologies. And trying to piece that together in a way that makes sense can be challenging. It can be time consuming. It can increase admin costs, and truly not being able to leverage that data in a way that's foundational, especially when it relates to key organizational priorities. I'll add a third area, access to care. 53% of the executives said access to care data is critically important. 100% of them are saying we're going to go ahead and we use that access to care data because we want to support that member journey. But again, when it came to the quality of that data, the data was poor. So there's processes, there's foundations in terms of being able to use this data, but when you think about that quality of data, it's absolutely poor. So how can we collectively as an industry work together to bring more concise, better methodological ways of bringing data together that makes sense in a way that's going to be useful for organizations, especially in support of their organizational priorities?
So, Dr. Hansen, it's interesting. So we've talked about these survey results quite a bit in the last few weeks since we got the results back, and there's some things some of our clients and payers that we've talked to have said. And one thing that really resonates that an executive said back to us, because this was all executives that we interviewed, director level and higher, talking about performance metrics and the impact they have, the impact that network design has on strategic priorities. And one of the things that resonates is that we're data rich, but we're information poor.
Yeah. Yeah, I completely agree. The real challenge is how, right? Like we've digitized so much, and that's great, but that's less than half of the work, right? And so I think a good example of that in terms of network curation is in the fact that total cost of care and HEDIS, reflecting cost and quality, are sort of the standard, which it's adequate, but it's certainly not sufficient. And for a couple reasons. One is it's way too summative. It's not formative. You can't really understand what you do with that information as much as if you're able to dig down and understand process a little better. Those metrics also are arguably not easily applied to specialty network curation. Like maybe they're sufficient for primary care. Probably they're sufficient for an entire network. But the problem is, what we have to decide is who should be on the varsity squad and who should be on the JV. We don't get to put everybody on the court at once. And so, like on the cost piece, I think it makes a lot of sense to use episoding. And there are, we're all familiar, I think, with sort of surgical or procedure-based episodes with a 30 or 90-day window. But there are also episode approaches that last 365 days, which would allow you to understand, for example, how does a cardiologist manage AFib? Or how does a endocrinologist or a nephrologist? You can imagine that those specialties are essential to a good network and to delivering good care. Their episode length is not going to be 90 days. They have ongoing relationships. So I would say that the episoding is important. And I'll just harken back to, I think, something, Bob, you raised, or something that you raised that got me thinking about transparency, how important it is that not just to have these metrics, but to understand where they came from. So episoding with transparent definitions so that everyone involved, including the providers, can understand why they're being assessed the way they are. And what that will allow us to do, in addition to understand cost, sort of observed to expected cost, is to understand specialty level, episode level quality in a much more nuanced way than HEDIS does. Like, HEDIS is really important, and it is probably the right thing to set your compass to. But again, like, so let's take A1C as an example. You know, the A1C at goal is a function of many steps along the way. And a good episode will allow you to understand where in that arc of treatment a provider may be failing. Maybe they're underprescribing, or maybe they're not seeing the patient often enough. Like, that level of detail is important in understanding, is the HEDIS outcome a function of the endocrinologist, or is it a function of some other externality or associated provider? I think it's important to be fair when we approach network curation, fair to the providers, because it's only through that the system will be seen as legitimate and people will buy into it.
Dr. Hansen, I love your perspective around episodes of care, especially when you talk about underperforming and, you know, ultimately what the outcomes are from a member perspective. What is your perspective around providers that are, let's just say, overperforming or adding additional diagnostic tests that may not necessarily be something that aligns with the condition of the member in order to get them ultimately to the right treatment, best treatment as possible?
Yeah, I mean, so certainly appropriateness is essential to a sustainable health system. We've had the luxury, I would argue, in our country to not have to reckon with that the way that many other countries have. But that isn't, like I said, it's not going to allow us to have sustainability of our programs. So figuring out a way to identify individuals who are inefficiently using care is essential. I mentioned earlier that in one of my experiences, I was a helper in supporting a capitated arrangement for providers, and that was very formative to me, to see how when you make clear to providers the costs associated with their care, and you ask them to manage appropriately with a target cost, they become much more thoughtful. Now, what's key to that, though, is you have to give them the ability to manage thoughtfully. And so in systems that are highly tuned to productivity or volume, a lot of reactive behaviors develop, and that can lead to testing when a little bit more thought or a little bit more discussion with the patient could have avoided that. So I'm not a believer that we can just like turn the screws. Like, that's going to lead to a bad situation. Arguably, that's where provider burnout is getting most of the fuel right now on the fire there. So what we have to do is, as we give that accountability for cost and appropriateness to the providers, we have to give them the space in their day to manage appropriately. And that will involve necessary changes in models of care, team-based care, so that the providers have an alternate in that sort of ongoing diagnostic and therapeutic management. They have an alternate to referral to a specialty, referral to additional testing. There can be someone who can help them distill out what actually is the best care at this moment for this patient.
From your perspective, it sounds like there's a shift, a significant shift, and it's one that's been around for some time, but it's continuing to grow in terms of level of importance when you think about fee-for-service versus value-based care, and really helping to kind of focus around ultimately what are the outcomes, right? How do you ultimately improve those outcomes of members? What's your perspective on that?
Yeah, I totally agree that there's a shift, and I'll add. I mean, in addition to what I said before, the other dynamic that I think is worth calling out is whole patient or patient-centered care is a principle that I think is ascendant. That means a couple different things. I would say like it requires us to understand where a patient's at in what they prefer for their care experience and for the life that they have. Recognizing that there are a lot of patients that aren't ready to make the kind of changes that I might recommend to them. So how do we meet those people as they are and take them down a road to change that will optimize their health? I think that is, in that recipe, in that mix of all the available diagnostics we have, the right sort of alignment of incentives to providers through value-based care, and that mindfulness about what is a patient's preference. That's the recipe that will lead us almost naturally to a better system of care. But each of those pieces is essential. So, like to the point about a fee-for-service versus a value-based incentive system, we do need to change the payment model to get to something better. There's a kind of a tired saying, but I think it bears repeating that every system's perfectly designed to give you what it's producing right now. And so we have a set of incentives that have been around for many years, and it's given us the system we have. If we want the system to change, we have to change the incentive structure.
Yeah. I do want to touch on a couple of things that I think are pretty important when we're talking about advancing, evolving to high quality networks beyond network adequacy. And that's really starting to talk about consumerism and regulatory pressures, right? Because there's a lot of pressure to the payer from a regulatory standpoint. And let's be honest, consumers are getting smarter. They in their day-to-day lives, everywhere else they shop, right? They're shopping for things. They look for the, top star rated plumber. They look for the number one rated rocking chair, whatever it is. There's ratings, there's metrics, and that there's becoming more and more transparency into the quality of the providers that are out there as well. So how do we evolve as this consumerism evolves? I mean, I don't know that patients are shopping as much as maybe they should at this point, but I feel like it's going to evolve in that direction because we do it everywhere else in our lives. And so Dr. Hansen, how do you see that happening? How do you see that evolution happening? And then how important is it then to have, the A providers versus the B providers in your network if people are actually starting to shop it appropriately? Do they shop for an MRI, right?
The question gets me, I guess, excited. I'm not sure that's the right word, but like I've seen so many patients who don't exhibit shopping behaviors, and the reason is they're too sick. Their work, their energy is just sort of getting through the day. Like people who have a burden of chronic disease, not all the time, but we can't expect them to be thoughtful shoppers. Like we should make it easy for them because they have enough challenges in their life. So I would argue that I'm not sure regulation is the answer, but I think that whoever is the fiduciary for that patient should really be thoughtful about making sure the right people are in the network for that reason, because the patients, the members, the employees that they're responsible for, when they get sick, I don't think it's fair to expect them to they're not planning a cruise. They're like sitting there with pain or disability of some kind, and we need to support them. So what I think that does mean is that our networks should make it clear who's going to deliver the best services, and then make that path the easy path for the patient, whether that means less out-of-pocket cost to them, or proximity, or virtual care options to direct them to that source of care. There's a lot of ways to make that journey a little easier for the patient, and I hope that we can build those into networks more and more going forward.
Getting less homework for the patient, right? So, yeah, because I think you said it best when we first started talking, and you didn't mention it here yet on this call, but it's about the experience we can provide. It's not just about the one visit. It's not just about the outcomes, but how are we making their experience and their health journey better, right?
Yeah, that's right. That's right. And what it requires is understand. I mean, the tension is it requires understanding a person pretty well, understanding their preferences, um, and that is possible, but it does take some time, and it speaks to why adequacy is a bigger concept than just can we check the box, right? There has to be adequacy to provide fit, to provide a productive, high quality therapeutic relationship, because at the end of the day, often what we have available to provide care is mostly effective, but not entirely effective. And so the experience of care needs to make up the rest. We need to be sure that people that are receiving care feel respected, attended to, and listened to. And so those variables are, I think, an important. We spoke to this earlier, but it's a part of a quality network, absolutely.
So, Dr. Hansen, it sounds like you're talking about ultimately a trusted advisor, trusting the health system, trusting the hospital, trusting the payer to ultimately provide you guidance based on, to your point, the member's preferences. What provider can they gain access to? How can we get them over to the right provider, whether it's a primary care or it's a specific provider type specialty? And then, as we know, health systems, payers have access to thousands of providers. How do you pick the best of the best? This gets back to really thinking about the characteristics of high quality providers and helping to provide that best level of guidance for the member. They want to spend the least amount of time with the provider, but they want the highest level of care, right? And there's a cost aspect to it as well. If they're not getting the right type of care at the right time in the right place, and they end up back in the ER or back in a facility for a longer period of time, it doesn't create a positive experience for that member. To your point, if they're dealing with a sickness or a disease state, obviously want to be as efficient as possible, thinking about their episode, thinking about their disease state. And a lot of that is in claims, right? So we talked about, being data rich, but information poor. Claims intelligence is really key. There's actually, there's been a really significant shift in the industry when you think about not only the federal, but the local, state, local regulators on truly thinking about that member experience and starting to use claims intelligence to support policy. There's more than a few states that are going out there, they're looking at claims and they're saying if a provider isn't supporting members in the past 6 to 12 months, they should be removed. They shouldn't be out there in a public directory. They shouldn't be, for a member that, back to consumerism, a member shopping for insurance, they're going to select, they have a choice. They're going to select a provider within their network only to find out that provider is no longer servicing. That creates a very negative experience for members. And then even in the case you had mentioned around sickness, they might have a primary, but now they're trying to find a cardiologist or some other type of specialist. They're looking for that. If that provider is no longer providing service, that again, it brings them back to ground zero of having to start over again and try to find another provider that can ultimately help to support them. But the regulators are really strengthening their position in terms of claims intelligence, not only on the audits, but also corrective action plans and putting penalties around that to really hold payers and MCOs accountable for providing transparency in terms of not only the network that they are displaying, but that it's an active network. It's a real true nature network. It's a network that can ultimately help to support the members in their journey and overall care throughout their life.
Yeah, I'll add, the transparency point is a really important one, and it's closely related to interoperability. To the extent that those principles advance, we will certainly see patients feel more known when they seek care. And that, there's probably a lot of providers that we would look from the outside in and say they're not delivering the right care, but those providers are maybe operating in an information silo. And if they were well informed about a patient's history, they would in some cases make different choices. And certainly the patient would, I think anyone who gets sick enough experiences showing up somewhere and being surprised that you don't know that about me. we need to move past that. Like, there's really no excuse for that anymore. And so better interoperability standards, improved transparency, I think will help resolve that disconnect that we have and that patients experience.
Well, I think we could have a 3-hour conversation on all of this. But unfortunately, we're coming to the end of today's podcast. I do want to kind of summarize a little bit. Obviously, with the evolution of network adequacy, moving into not just patient experience, but patient outcomes, it's becoming more and more important to really leverage the insights and the data that's available to you. Like Bob mentioned in the Becker survey, the payers understand this is impactful. They understand network design is foundational to achieving their strategic priorities, as well as increasing access to care and better outcomes and a better just health journey for their members and for patients, right? We got to be thinking of that holistic care. And with transparency, into cost and quality of the providers, it's going to be really important to be able to provide that information easily to the members and to the patients so we reduce their homework, so that they can get the access to care that they need without having to be such an advocate for themselves that they're having to do so much homework to get to where they need to be. And we need to be, using the data to be able to help make that happen. So I really appreciate both of you joining us here today on the Totally Adequate podcast. I think this has been a very insightful conversation. I hope you've had fun. And to everyone out there who joined us, thank you for joining us on the podcast. We know you have a lot of options of where you get your information and the podcasts that you watch. We are honored that you joined us here today. Please remember to leave any ratings for us. Those help us out, give us information about how we can provide topics that are of interest to you. And also, just to let you know, Totally Adequate podcast is produced by Fowler House Films and Sophia Timmermeyer. Thank you again, everyone, for joining, and we'll see you next time on the Totally Adequate podcast.
Thank you for tuning in to this episode of the Totally Adequate podcast. If you enjoyed it, we'd appreciate it if you could rate us on Spotify or leave a review on your preferred podcast platform. Your feedback helps us grow and bring you even better content. We also invite you to send us any comments or topic ideas by emailing us at thetotallyadequatepodcast@questanalytics.com. The Totally Adequate podcast is produced by Fowler House Films and Quest Analytics. Thank you for listening.